Hi, my name is Travis Greenrath, and this will be my quick kind of 10-minute but final presentation overview for addictions overview for this semester. So let me adjust this, make sure I have the angle right. So in terms of going through succinctly the textbook itself, so in the first part, really the first section of the book, we're covering a couple aspects. Most importantly, first off, we're covering the history and ideological models of addiction, the disease model, the moral model, right? The moral model being it's a belief of having to pull yourself up by the bootstraps, right? That if one suffers from, alcohol use disorder or another substance use disorder, it's a matter of them not having enough willpower. Or also morality, that they're, deviant, perverted, whatever the case is, and that was the prevalent ideology for most of human history until we have the evolution of the disease model, partially based upon the work of the Washingtonians in the 1840s, who are also kind of the start of peer support groups, which we see later in, the Oxford group, and then, of course, Alcoholics Anonymous and 12-step programs. The disease model more views substance use disorder, stemming really from AA, Washingtonians Oxford group, views substance use disorder as a mental illness, but more than that, as a disease. It has the components of a disease. It's chronic, ongoing, it's chronic, progressive, ongoing, and ultimately terminal if not treated. And it also views that it's not a moral failing of the individual, but rather, a disease that requires medical and clinical treatment and intervention. And in recent years, there's been more recent models as well, such as the recovery model, which is looking more at the positive and upsides of recovery, viewing it as an opportunity. But one I found really interesting that I did not know about, I'll pull up the exact wording because I liked it a lot, was the looking within personality theory model I found interesting. It's an assumption that certain personality traits are predisposed to drug use or alcohol use, basically the addictive personality theory. And that's had, relative waves of credibility, but I've already spent 2 minutes just on the first chapter in the first section. But the other parts, the other chapters of this section go over the various substance addictions, alcohol use disorder, cocaine use disorder, or stimulant use disorder, cocaine, amphetamine type, depressive, anxiolytic, sedative, hypnotic, and then it touches also on hallucinogens and a little bit on inhalants. Inhalants is an interesting area because despite the fact that inhalant abuse has been around for, at least recognizable in U.S. culture, at least 50, 60 years now, there's still not a whole lot of substance-specific treatment for inhalant use. And then, of course, getting into important professional practices, problems and issues when working with addiction and individuals struggling with addiction. Something that really resonated with me in that chapter was touching on the importance of counselors who are in substance use recovery to kind of keep an eye on themselves, to maybe practice more self-care than your average, or not average, but fellow counselor not in substance use recovery, and also to look out for an emotional over-identification with the client, a powerful countertransference. It's something like I've experienced in my lines of work under my LCDCI license, and that really resonated with me as well. And one thing I wish they had included in there, they kind of touch on it with the self-care, but I wish they'd really emphasized was that counselors in substance use recovery make sure that their job working with people struggling with addiction is not their recovery, i.e. that counselors in recovery do not tie their personal recovery, success and growth to the clients they're working with. A, it's an unfair burden to the client. You're making the therapy about you instead of them. B, clients don't always make it. Sometimes they pass away or they relapse or whatever the case is. And then the next chapters get into assessment and diagnosis, which I've had a good amount of experience working with, doing DSM-5 diagnoses and ICD-10 codes, working in a residential treatment center. So a lot of that was kind of old hat for me, but it's always good to go over. I especially like how it leaves openness for clinicians' interpretation on some of the disorders, meaning like the difference between mild and moderate, 3 symptoms, 5 to 6 symptoms, and then greater than 8 or 9 symptoms for severe. But I think my favorite part in the whole book, in terms of just what I felt like was the meat and most effective for me, was all of part 2, the various treatments and interventions. Most specifically, psychotherapeutic approaches. I loved how the book broke down cognitive behavioral therapy and why it especially works with substance use disorders. It really touches on how, on the basis of a lot of substance use disorders, is cognitive distortions or negative cognitions, revolving around shame, lack of self-efficacy, isolation, and how CBT really seeks to challenge those things. And then, of course, also how CBT can be very effective in combating triggers and cravings, and a lot of those phrases of play the tape through, and looking to change people, places, and things, not as a cure, but into aid and kind of, that cognitive change, or as it later talks about in the 12-step programs, that quote-unquote psychic change, the change in one's thinking. And all of that, of course, is still really based out of the disease model, that it's to be treated, similar along the lines of another mental illness, such as schizophrenia or bipolar. And similar to those, there's also pharmacological interventions, such as gabapentin, naltrexone for managing cravings, reducing cravings, right? And also antidepressant medication as the comorbidity between, especially alcohol use disorder, opioid use disorder, hypnotic anxiolytic sedative use disorder, and major depressive disorders is very high. That a lot of those medications can be helpful. Also, Wellbutrin as a helpful medication for reducing cravings for nicotine, because can't forget to talk about nicotine with stimulants. And then, and I also got some experience, I want to touch on this, in doing relapse prevention plans and relapse autopsies, working in residential. And I think it's a very powerful take, because when you hear relapse, most people think of failure. They think of something to be kind of swept under the rug, or, pick yourself up, try again. But what I really love about relapse prevention, and specifically relapse autopsies, is instead of trying to pretend that relapse does not occur, we accept that it may, and see what can we get from it to be more beneficial. With another mental illness, such as high severity schizoaffective disorder, relapse is a high possibility with many individuals. And if someone, has a relapse in their mental disorder and, into a psychotic episode or something like that, or, return of hallucination and delusion, you don't treat it as failure, right? You look at what things led up to it, if there was anything that the individual could have controlled, if there's any supports that could be provided, ultimately use it as a learning experience. And so I'm grateful that it's also been applied to the disease model of addiction. Now, what challenged me the most about this book, and I really appreciate it because it pointed out a lot of my own personal kind of ableism, and my own privilege of not suffering from any intellectual or developmental disorder. And I'm grateful that they contributed a whole chapter just towards persons with disabilities and substance-related and addictive disorders. Now, the chapter is not just addressing, individuals with IDD and a substance use disorder, but I want to read over this because it really stuck out to me, just barriers to treatment for persons with disabilities and things that I never really thought about. Like that certain materials, advocating someone to go get help, like even you think about just pamphlets, do you struggle with your drinking, right? That those might actually be written at too high a reading level for persons with an intellectual disability, as a barrier not only to recovery, but just help seeking in the first place. Or they're unavailable in formats that are accessible to persons with visual impairments. That's a direct quote. But this chapter really opened my eyes to that there's a huge population of people that suffer from various disabilities, whether they're physical disabilities or physiological disabilities, I should say, that are differently abled, intellectual developmental disabilities, whatever the case is, that have all these barriers, and on top of that, the societal stigma that these individuals have already faced for those disabilities, and then feeling like you kind of get caught in, a double winner in a negative way, right? There's already the stigma of the disability, and then on top of that, the stigma of a substance use disorder, right? And then even if they enter into a peer recovery community or something like that, where they may be accepted for the substance use disorder, they may still face stigma, you know, because of their disability. And that's not just true of peer support groups, that can be true of providers, mental health. A lot of people who suffer from disabilities have an unfortunately, experienced negative view of mental health providers due to stigma, misdiagnosing, and just, I avoid the term malpractice because that has a conscious intent to it, but I should say if there's a term such as mispractice, I guess malpractice too would work with that. And in the final section, touching on cross-cultural counseling for addictions, right? And looking at specific cultural factors such as, like in a lot of Latin American communities, alcohol use disorder and sometimes stimulant use disorder, but really more cannabis use disorder. There can be a lot of barriers to help seeking that are based and heavily rooted in kind of cultural values, such as the prevalence of alcohol in Latinx culture, and that combined with the kind of very community insular nature of problems that a community member has need to be handled only within the community, or only through a faith-based route, and those can also sometimes those can be tricky because they can be barriers to help seeking potentially, but that calling it only a barrier also limits the possibility of those communities empowering their own members in recovery. And so that knife can cut both ways, right? It can lead to people not seeking help because of their own, cultural stigma they come from, but it can also lead to providers making incorrect, stereotypical assumptions about a culture and ignoring potential strengths and natural supports that could help an individual in their recovery process. And then as a bisexual man myself, it really touched on, or I should say, I apologize, it's late, but, as a cisgender, male-identifying bisexual man, the chapter that touches on substance use disorders in the LGBTQIA plus populations is powerful. That there's, it talks about the problems of the higher rates of stimulant use disorder, especially amphetamine-type substances, in the male homosexual community, and also just the stigma in terms of barriers to, society, similar almost to disabilities in a way of the double stigma, again, right, of LGBTQIA and substance use disorder, and also how in some of those very insular LGBTQIA communities, substance use is prevalent. And so, anecdotally, not as much from my experience, but friends of mine that are in long-term recovery here in Lubbock that, are members of the LGBTQIA community, a handful of them that I've talked to, this is anecdotal, so it's not evidence-based, but anecdotal, they had experiences where they had real fears about, if I quit drinking and using, how am I going to engage with my LGBTQIA community? Since a lot of, common, I guess you could say, cultural bastions for LGBTQIA communities have traditionally been bars and clubs and things like that, where people can be kind of more free to express themselves. As someone struggling with a substance use disorder, that place might be really dangerous to you. So how can you engage with your culture without sacrificing your recovery, and protect your recovery without sacrificing your culture? So I'm glad that the chapter really addressed some of those difficulties that may not come up with, heterosexual or sexually typical quote-unquote populations. I'll stick with heterosexual because I don't think there's such thing as sexually typical. And then the last one, which of course, Dr. Cruz, you said I'd love to talk about, inpatient, outpatient addiction treatment going all over the managed care model, in the different ASAM levels of care. And I like how it touches on, the therapeutic interventions used at that level, a lot of SFBT, which is similar to residential, because you only have people for a limited amount of time. You're not necessarily going to go into a 2-year-long psychodynamic therapy plan when they're only going to be in your IOP for 10 weeks. So it's a lot of solution-focused brief intervention therapy. And I really appreciate how they went into depth about kind of, they touch on the billing, but really how in the inpatient and outpatient settings you have to have a balance between, your DSM-5 diagnosis criterion and working within the managed care system. And that has to find a symbiosis with counseling and therapeutic interventions like SFBT and what modes are evidence-based and billable, and how can that be beneficial to your client. I think that's something that this program's done a good job of touching on in previous courses about that tightrope between billable and helpful, and trying to find where those two cross over as much as possible. I'm already at 15 minutes because I love to hear the sound of my own voice, as you can tell. The last question you asked for this final was, any assignments that could have been different. And I'm really trying to think, because I enjoyed a lot of them, and I've worked with you, on the intro assignment on the genogram. We worked together on an alternative assignment for the meeting attendance as well. I can't think of any that could be particularly different, honestly, because you made those accommodations. One thing I would suggest for future assignments with the meeting attendance, it's not even a suggestion, I'm just really curious to know, selfishly, what members of my cohort thought about going to meetings and what that experience was like for them. I would love it if, like, in the future, there was like an open discussion board at the end of the semester that was maybe extra credit, or something, so people will actually do it, where they share, as much as they're comfortable with, what their experience was like going to meetings, what that was like for them, and what they learned from it, what they didn't like about it too, problems they had with it as well. Because I think that would just really encourage that dialogue rather than it being just kind of a hit 4 meetings, write a little paper, and move on to the next thing. I think it would really encourage, especially since, you never know. There might be some members in our cohort right now that are, potentially already in or are developing substance use disorders, and those rooms of recovery may be helpful to them later down the line. So you never know. But with that being said, I'm at 17 minutes. I think I've done a pretty thorough job in covering the chapters and what I got out of them. So please let me know if there's anything else I need to do, Dr. Cruz. And on a final note, I just want to say thank you for talking to me on the phone the other day and guiding me through these assignments. And it just kind of helped me get my head back on track with the end of the semester. I was looking too far past the finish line. And you brought up the Recovery High School, and that got me excited for that again, and reoriented me to things I can be looking forward to without looking too far ahead. So, just thank you, Dr. Cruz. I appreciate it.